Welcome to the Clinical Assessment Kit on Schizophrenia PowerPoint presentation prepared by Angelica, Kayla, Sharian, and Susan. We hope you enjoy the presentation.
Schizophrenia is a chronic psychiatric illness characterized by positive symptoms, delusions, hallucinations, and grossly disorganized speech and behavior. Negative symptoms such as apathy, social isolation, and diminished effects, and cognitive impairment. Any combination of these symptoms can lead to marked disruption in behavior and significant negative effects on functioning and an increased risk of development of many comorbid health problems, suicide risk, and substance use disorders. Thus, my colleagues and I have created this assessment kit to be used as a tool to analyze the contributing factors of an individual's symptoms, to gather information, to accurately diagnose clients, and to create treatment plans that are specifically tailored to the client's needs. This assessment kit is used to identify, address, and measure clients' behaviors, as well as rate the severity of the client's symptoms. This assessment kit is a necessary element of therapy as it helps the clinician to understand the uniqueness of each client. In addition, the tool gives us understanding concerning the client's psychological functioning, emotional well-being, and behavioral patterns. Lastly, the clinical assessment is a tool that can be used to track the client's progress. As it relates to psychoeducation and treatment, our treatment plans will be individualized and services will be provided based on the client's specific needs. We will provide cognitive behavioral therapy, which helps the client to identify and change any negative thoughts or behavior. CBT aims is to help the clients to cope with symptoms like psychosis or delusions and hearing voices. Based on the assessments, we will provide clients and families with education of the diagnosis, ensuring that all myths and concerns are addressed. We will provide verbal and written communication of the diagnosis, such as handouts and homework. We will also strive to ensure the client is knowledgeable of the common symptoms and coping skills to deal with those symptoms. We'll provide family therapy to make sure that families are knowledgeable of the client's diagnosis and are active in the client's treatment, including information supporting the do's and don'ts when interacting with the clients. We'll also offer group therapy services for the client so that they become more familiar with their diagnosis and can also engage and communicate with other clients with the same diagnosis. We'll provide problem solving, communication, and self assertiveness training. In addition, providing suicide prevention services for the clients and information concerning different medications and their side effects. Domain 1 focuses on the presenting problem and includes the primary issue or concern that an individual is seeking assistance for, and in this case, it's schizophrenia, in which I highlighted the brief clinical assessment scale for schizophrenia, which is a 14-point scale that focuses on symptoms that are listed in the DSM-5 or the positive and negative syndrome scale. So those covers questions concerning delusions, hallucinations, mania, lack of insight, depression, anxiety, obsessions, memory loss, etc. And there is a 4-point scale, 1 being there is no problem, 2 there is a mild problem, 3 moderate problem, and 4 severe problem. The brief clinical assessment scale for schizophrenia is a condensed assessment that is based off of the positive and negative syndrome scale, which is highly successful but can be avoided because it is on a 7-point scale and it can take 30 to 40 minutes to complete with a client. However, the goal is to assess the severity of the client's symptoms. Hello, everyone. So, for 1.2 family background and situation, I have selected assessment tool PNSQ questionnaire. This assessment is designed to capture information on the following various situations and experience that some family members may experience from their loved ones. And within this tool, it asks questions about what the family member may see within their loved one, like their thoughts and the things that they do. For 1.3 physical functioning and health, I have decided to do another PNSQ questionnaire. Within this tool, it gathers information on health history, pain, and functional limitations. So within the tour, they touch bases on questions about their work environment and traveling from place to place, and also doing like recreational activities. So I thought this would be a great tour to be able to gather information and collect data on the patient to see where they are physical and to see how we will be able to assist them.
Section 1.4, Educational Background and School Performance, was divided into 3 separate sections: learning style, intelligence and cognitive ability, and nonverbal learning disorder. There are 4 theories of learning styles. The theory that we have selected is the VARK model of learning. This is a 16-question self-assessment used to help identify how the client learns best, whether it be visually, listening, reading and writing, or through a hands-on approach. This questionnaire is designed to help identify tools that can be used to help the client in their treatment. You can see from the chart that studies show every age group prefers the kinetic style of learning, the hands-on approach. We found through our research that while clients may think that they prefer one method over another, it may not be the style that works best for them. Generally, it's a combination of the tools that are used that show the greatest success. Section 1.4.2, Intelligence and Cognitive Ability, discusses the choice of using the WAIS 4 short form, which was designed for clinical use when time is more important than accuracy. A careful selection of the items chosen from the full-scale test were used to provide validity for the short form test. There are 4 cognitive areas represented: reasoning, information, math, and coding. This assessment is not meant to provide an IQ, only to assess areas of intelligence and cognition that may be of concern when treating a client with schizophrenia. 1.4.3, the final component of the educational background and school performance, considers nonverbal learning disorder. Our choice in assessing this is to support the direct correlation between nonverbal learning disorder and schizophrenia. This assessment looks to provide insight into deficiencies in the areas of visual, spatial challenges, math, body language, and social skills. These deficiencies can also be found in other learning disorders such as ADHD or Asperger's, so we're utilizing this assessment to avoid misdiagnosing the client. Section 1.5. In evaluating the client in the domain of cognitive, psychological, and emotional functioning, we've included questions about thought patterns, distortions, experiences, mood trauma, and self-esteem. We've chosen the mini mental state exam as the tool, as it can be administered by anybody trained in cognitive impairment testing. This exam has been used for an array of mental health diagnoses. In determining the level of functioning, the mini mental state exam covers 5 areas. Orientation, as it explores awareness of time, person, place, and situation. Registration, which refers to the ability to take in new information. Attention and calculation, which assesses the ability to listen and perform a function with recall, indicating how well you can remember recent events. And finally, the use of language, as the client explores their ability to find the right words to convey their message. This exam has been a reliable and valid screening tool for an array of mental health diagnoses. Section 1.6.1 talks about the interpersonal and social relationships of the client. We will use the relationship scale to determine how clients view their relationships with their families and their friends. 3 components we've highlighted from this relationship scale are cohesion, expressiveness, and conflict. Cohesion can be defined as the act of sticking together. Expressiveness, the state of showing what someone thinks or feels. And conflict, a serious disagreement or argument. In any relationship, it's important that you have these 3 components. Section 1.6.2. Continuing on the slide is the loneliness scale. Loneliness is defined differently than isolation, while both are subjective feelings. A person can be lonely even when they're in the company of others, and feel isolated in the same situation. Here in section 1.7, we've explored ethnicity and culture by using the biopsychosocial assessment as a starting point. From there, we followed the guidelines from providers of psychological services and elicited more information. This information included how the client was feeling about their own identity and their ethnicity. We explored things about traditions they had when they were growing up and supports that they especially have as related to mental health treatment. We all know that different cultures have different perspectives. It's important for the therapist to consider all of these factors and to be culturally competent when treating the client. Religion and spirituality are covered in section 1.8. 1.8.1, we'll talk about religion. Our research shows 45% of patients indicate religion as important in their life, and of those 45%, 60% use religion extensively to cope with illnesses. We started this assessment by asking a general question: what helps you to cope? If the client does not mention religion or spirituality, we move on to the next assessment. However, if they do mention it, express it as a source of strength, we continue with this assessment. The purpose of this assessment is to identify the presence of positive or negative effects on the client. Studies have shown that religious beliefs can have both positive and negative effects. Among the positive effects are the power of prayer, but the negative effects on the client could result from guilt, shame, or fear, and they can provoke feelings that God has abandoned them and even view their illness as a punishment for sins they may have committed. Although guilt can be unhealthy, healthy guilt can be used to protect your integrity and self-esteem. Section 1.8.2 switches over to the spiritual side, which may or may not have religious undertones. There are positive effects, such as spending time in nature, finding purpose in life, and using meditation for many clients. But the negative effects of spirituality have been shown to provide false hope or result in extreme thinking. The old adage, "that's karma," can be used as a positive or negative aspect of spirituality. The use of this assessment scoring was to determine the level of impact religion and spirituality may have on a client's current situation or their treatment plans.
1.9 for gender, the focus will be gender identity and sexual orientation. For this tool, it will be utilized when asking individuals about their gender backgrounds to get a little bit more in depth on the patient's preferably gender and how they express themselves. So questions are captured to better understand the individual and their gender background.
1.10 Strengths and Problem Solving Capacity. The first tool used for this domain is the Strengths and Difficulties questionnaire that was developed by Robert Goodman in 2009. This version of the questionnaire is for adults over the age of 18 since the original SDQ is meant for children and adolescents. The questionnaire has 25 items and covers 5 different domains. The domains include conduct problems, emotional symptoms, peer problems, hyperactivity, and prosocial behaviors. After the 25 items, there are follow-up questions that ask about how the difficulties affect everyday life for the client/patient. This is a useful tool to help identify strengths and difficulties that the individual has. This tool was found from an article written by Brand and their colleagues. Their study examined the SDQ adult version with participants. Results from the study show that results from the adult participants are very similar to the results of those of the adolescent version. The results from the study support the use of the SDQ for adults in mental health services. The second tool used in this domain is the Carver Brief COPE Inventory that was developed by Charles Carver in 1997. This is a shortened version of the COPE Inventory that was created by Carver and his colleagues in 1989. The Brief COPE Inventory is a self-reported 28-item questionnaire. The questionnaire uses 14 scales that has 2 items each. The 14 scales are active coping, planning, positive reframing, acceptance, humor, religion, using emotional support, using instrumental support, self-destruction, denial, venting, substance use, behavioral disengagement, and self-blame. The responses to each item are 1. I haven't been doing this at all. 2. I've been doing this a little bit. 3. I've been doing this a medium amount. And 4. I've been doing this a lot. The completion of this tool will give insight of what coping skills the client uses in stressful situations. This tool was found in the article written by Charles Carver. In the article, he explains his reasoning for creating a shorter version of the questionnaire because of it being redundant and patients feeling impatient while completing the questionnaire. Results from the study show that the scale has internal reliability and results was consistent with the full COPE questionnaire. 1.11 Income and use of community resources. For domain 1.1 Income and use of community resources, there is no published tool found, so we had to create a questionnaire of our own. The questionnaire was created with the help of the article written by Pinto and their colleagues. The questionnaire addresses the client's total family income, how many people the income supports, and questions about the use of community resources. The questionnaire is 10 items and is a mixture of open and closed-ended questions. The study by Pinto and their colleagues examines how patients feel when being asked about their income. Results from the study shows that a majority of patients feel comfortable when asked the questions about income and community resources. And results also show that female patients, caregivers of young children, older adults, and minorities were less likely to respond to the questions. 1. Here we have the last domain, which is 1.12 potential barriers to treatment. For this domain, we created a questionnaire with questions from the Barriers to Mental Health Services Revised that was developed by Pepin and Siegel in 2013. We were unable to obtain the BMHSSR online, so we used questions from the article written by Rice and their colleagues. The original scale is a 44-item questionnaire that measures 10 barriers that prevent people from seeking mental health services. There are two domains in this questionnaire, which are intrinsic and extrinsic barriers. The intrinsic barriers are self-help seeking attitudes, knowledge and fear of psychotherapy, stigma, belief and inability to find a therapist, and belief that symptoms of depression are normal. The extrinsic barriers include insurance and payment concerns, ageism, concerns of the qualifications of the therapist, physician referral, and the transportation concerns. The questionnaire created for the assignment is 10 items and focuses on both domains of the BMHSR. Another article that helped form our questionnaire is written by Kishore and Saji. And the article focuses on the use of the BMHSSR in clinical practice. This study shows that intrinsic barriers were higher in existence than extrinsic barriers are. They also found that both genders report higher intrinsic barriers than extrinsic barriers. Useful strategies that we learned that would be effective when working with clients. This assignment really helped us learn different assessments that we can use with the population of schizophrenia. We learn to record self-reporting symptoms, but also be observant and note what we view the client saying and doing. We learn to use evidence-based assessments. We also learn to consider social location when interacting with clients, as well as use reflective practices, and lastly, focus directly on the client's needs. Useful strategies Critical analysis of the group collaborative process. Overall, the group was very effective working together. We all come from different backgrounds with different experiences, and our differences really helped each other come up with different ideas for the assignment. The group communicated via Zoom. We held a few Zoom meetings to talk about the assignment. We also utilized a group chat where we were able to text each other frequently with questions. We split up the assignment by domains, which was very helpful. Group members provided each other with support and helped one another if we were confused and had questions. One weakness we had in the group was starting the assignment a little bit late, but we were able to get back onto our feet once we split up the domains.
We hope you enjoyed our presentation and found it very informative. Listed here are our experiences. Thank you for joining us.